First, welcome to Don't Look Surprised. Your patients want Botox. I was looking for a topic to speak to you guys. At Pankey, people always know everything, so I figured let's talk about something that's a little off the beaten path for us and something that's near and dear to my heart, which is Botox. So, first of all, who am I? Really, what I am is, this is a little example of me as being a Zoom expert during one of my recent classes online. I'm still figuring out Zoom. I'm forgetting that I'm on video. Some of my classes, I'm getting an MBA right now. They're running a little bit late online, so but my fellow students got to go ahead and do that and have some fun with that. But basically, you can read about me later. I think they have something. Let's just get down to business here. So first of all, and patients will ask this, and a lot of times we don't necessarily always remember, or maybe something to kind of help jog our memory a little bit about exactly what is Botox. And Botox is, as you can see here, a Clostridium botulinum. The lethal dose for this is 2 million times lower than curare and 1,000 times lower than diphtheria. So it's some pretty potent stuff there. It is found in soil. And you've heard about botulism and how you can get that from contaminated food. And some of the effects that you get from that is difficulty swallowing, double vision, salivary gland activity gets reduced. And then you'll also can have death due to respiratory paralysis. And you'd ask, well, why the hell would people want to have this put in our face? And we'll delve into that a bit more in a second here. So, and again, when I ask patients ask this, I'm located near Tulane University out here, Loyola University. I get a lot of PhD people, and they commonly want to know how things go. And if you can't answer, they get quite apprehensive to go ahead and move forward with treatment. So I figure a really good way for us to look at this is, you do a slow-mo video here and just kind of give you some description of what's going on here. So basically, right here, you'll have our digital lady here. Doesn't love these little 11s and other wrinkles that are caused in her forehead here. And so what we're going to do is examine what causes this muscular movement. And so initially, we'll have this nerve stimulus will occur. And this is just going to show how it's moving down the axon, muscle cell contracts. Another nerve impulse comes, muscle cell contracts. So now we're going to go a little bit deeper into this, into what's going on at a more of a molecular level here, a cellular level, I should say. So you'll see these synaptic vesicles that are in there, and I know this is a review for some people, but it's been a while. They'll contain our neurotransmitter, and they're going to course toward that cell membrane there. And when it fuses there, it'll release some of this acetylcholine into the synaptic cleft. And then when this acetylcholine binds, it'll release that acetylcholine, and then they'll get in those postsynaptic receptors of the motor muscle, and then we'll get a depolarization and contraction of the muscle. Now, in the midst of Botox, we'll go ahead and inject this in now, and then this will get taken up into the cell. And basically what this is doing is these little complexes you see there are called snare complexes. And what they do is they inactivates one of the proteins within that, so it won't be able to bind and release that acetylcholine, and therefore you can't get a stimulus of a conduction. And it takes some time. This obviously will reform again. There's sprouting and other things that will form that will eventually lead to snare complexes being able to be formed again, so that nerve conduction and muscular movement can resume as normal. Some of the wrinkle facts we have here, and as you can see, our patient here is wrinkled, and I'm going to let him make an appearance here and potentially in a moment. But this is my dog, Bruno. So there's 43 muscles in the face. I know most of you guys know that, but we have over 10,000 unique facial expressions. And the muscles on the face, as opposed to some of the other areas in the body, are quite close to the skin on the face. So when we go to, for instance, one way to see this is if you were to go and take your cheek and kind of smile or talk, you'll feel it kind of instantly tighten a little bit because the muscles are attached quite close to the surface of the skin, as opposed to somewhere deeper where you may pinch the skin of a bicep or a leg and you do some contractions and you don't feel that same pull of the skin there. And as we age, unfortunately, the production of our collagen and elastin tend to diminish a little bit. That gives us some of that quicker recovery of the skin. And so what the Botox essentially does is it's going to cause a temporary relaxation of the skin. Notice I don't use the word paralysis. It kind of scares people a little bit. Sometimes we say the word paralysis. So temporary relaxation, I guess you can say, is more of a nice politically correct way of saying what we're doing there, and it makes people more comfortable. And what it does is when that muscle is not contracting, that collagen elastin over the top of that skin has the ability to recover and tighten that skin back up, thus reducing wrinkles. And at any time as well, with the chat box, please feel free to type in any questions. If it's something that we'll get to, obviously I will let you know, but questions during this, I know we don't have the ability to speak right now on the Zoom as we would in a live class. But if you can type some questions, feel free to, I'll definitely stop and take a look at those and try to answer those as much as I can during the presentation. So when does the Botox work? It takes about 1 to 2 days. And I'll tell you, most of the time I get it tends to be, well, I used to say young ladies, and I'm not trying to be sexist there. It just tends to be the composition of most of what I have. In my area, I tend to almost have a 50-50 split of men and women, but it does weigh a little bit more heavily to women that come in. And they get the Botox, they leave, and that night they say, well, my face is still moving. I said, well, you got to wait and take some time, even when you tell them that. But you're going to want to tell them that you won't experience any effects really until 1 to 2 days. Now, that being said, those effects aren't going to necessarily mean that all muscle movement just ceases completely. It'll just be that, okay, it's a little bit more difficult to move my head around, or, the squinting is a little bit more challenging than it was a few days ago. But it usually takes about 2 to 10 days and for that stuff to really start to really show. And the reason for that is it takes about that long for those snare complexes to get, those proteins within them to get inactivated by the toxin, by Botox. And that's the reason it takes a couple of days. The peak effect is in 2 weeks. And as you'll see, in 10 to 12 weeks, so usually we'd say about 3 months, is when those snare connuins will form again, and then the muscle action will be able to occur again. So, how long does it work? I usually tell them 3 months. Now, in the very first treatment, somebody comes in, and we're going to talk a little bit more about it, but somebody who's extremely expressive. Some people almost talk with their forehead. Everything they say, they're, always doing this, and very animated people. I'm going to tell them that you're likely going to be on the shorter end of the spectrum in the beginning. But, interestingly, with Botox, in deference to some other things, it tends to perpetuate a little bit longer. It tends to be a little bit more effective as you go on, because as you continue to get this, the muscle does tend to atrophy a bit. And so when they do get that same dosage again, it tends to last a little bit longer. And there is some element of behavior modification to that. The body can get used to a little bit to, okay, I haven't used that muscle in a while. They begin to get a little less expressive with those motions as well. And I'm seeing some people's Botox last anywhere from 6 to 9 months. Certainly not something I would promise people, but I would tell them in the initial thing, I would not necessarily promise them the 3 months ahead of time. I would tell them, this might be 2 to 3, but certainly as you do this, expect this to last a little bit longer. So there's several different types of this stuff, and there's actually several. I had seen 7 serotypes, and now I've read recently there's 8. Where there's botulinum toxin A through F. Now on the market, and what you're going to use primarily is a botulinum toxin A. Your 2 most popular versions are the ones that I see that you have listed here. Botox is, even though that's the term that we always use, Allergan has coined that term. So they still own that. Allergan's been recently bought by another company, I believe. But Allergan's still going to be what you see on these products. Certainly the most popular one. Xeomin is another one that's out there. It's gotten a lot of publicity recently because it works quite well. It doesn't have any additives in it, preservatives like Botox and Dysport has. So people are having a little bit less reactions to Xeomin. It's also been referred to as something we call a naked injectable. And the reason they call it a naked injectable is because it doesn't have those materials in there. And that also allows that to also be a less of an opportunity for anyone to develop any kind of resistance to this versus those that have additives in there. Xeomin also is a little bit less expensive. And there's a lot of people, and when I say people, just injectors, dentists and dermatologists alike, that are moving towards Xeomin. They're still talking to patients as if it's called Botox because that's the popular term for it, just like we'll talk about various clear aligners as being Invisalign, because if you start to talk to them about other versions of that, people just aren't as familiar with that name brand. So Xeomin is a really nice product, and that's primarily what I use at my office. But I've used both of these. They're both fantastic, and I don't think you could really go wrong with either one. The only other version I've seen that gets used, and it's rare, is a Botox B. It's usually referred to as MyoBlock. And the reason that's even around is that if you notice that you've done a few different dosages with A, and then that individual is just not responding at all, then you may need to move to B. However, extremely, extremely rare. And I have not seen it personally, and the chances of you maybe seeing it as well are not very likely. Typically, if that's the case, the dosage is probably a bit low, or there's something else at play, like maybe the Botox isn't good, or it's not placed necessarily in the most optimal areas. So I would always kind of err toward that first before you ever switch from A to B. And I'm going to go to the questions real quick. I see Gary asked, what's your average fee? Gary, my average fee on this is $12 in my area per unit. And we'll talk about it too, but I'll dictate how many units we're going to do. I don't like to advertise it like that necessarily. I'll tell people that's how much it is. However, we'll consult ahead of time and say, what do you want? What are you looking for? And I'll say, okay, you want the forehead to improve. Okay, well, we're going to put 30 units there. Therefore, 30 times 12 will be this. If I'm doing a Botox party, which mostly consists of just a large gathering of people that will come to the office, I'll do a discount to $10. And then I've seen it as high in my area at 15. I had a lady from New York who came in town and wanted to get Botox. She had said that in New York it was $20 a unit, which doesn't shock me because I know the cost of living and other things up there is a bit higher. But it's $12 has been the sweet spot that I've found that never really gets. It's about maybe $1 or so less per unit than the dermatologist. Now my cost on this is typically about $6.05 a unit. So I'm getting basically 100% markup on those. Who makes Xeomin? It's going to be Mertz Aesthetics if you see it at the bottom of that box there. Okay, we'll go ahead and continue on. Again, thank you very much for the questions. You can keep them coming. Now, Dysport, many of you guys have heard about Dysport as well. I think it's a fine solution to use as well. I think that if people want to, if people say they've had great results with Dysport, I've heard about it. I've used it before. For me personally, I didn't experience as much success as I had with the other kinds. That being said, I would never talk down Dysport. It is another botulinum toxin A that you can use, and it works very well. Now, one thing you'll see about it is those other ones were 100-unit vials. You'll get those in 50-unit vials. Dysport comes in much larger, 300, 500-unit vials. The reason that these are much larger is, and we'll see on the next case, or the next page, sorry, is that the Dysport is, the dosage is much larger. Now with Dysport, one thing is you have to use this, typically is recommended at least, and I know people always have these secrets how to make them last longer, but is to have them last for 4 hours. That's a pretty short amount of time. And typically you're not gonna go through an entire bottle of Dysport every time, and you hate to waste any of this stuff. It's still not extremely cheap. I mean, Gary, if you did the math there at $6.05 a unit, I'm paying over $600 for a vial of this stuff, of Zeamin and allergens, even increase their costs as you know, expected with inflation and other things that raise costs anyway. You know, these can be fairly expensive. You hate to waste a drop of this stuff if you don't have to. And so, you know, how long does the other stuff last? They'll say typically that they would like you to use it within 24 hours of the time that you mix it and reconstitute, and we'll talk about how to do that in a moment. However, if that's with preservative-free stuff, and typically you can have these things last up to 4 weeks, and with you put it in the refrigerator, and I've had it last quite well. After 4 weeks, I typically won't use it, and I wouldn't even use it at that time 3 or 4 weeks if I didn't have to, but sometimes we do, and I've noticed that the effects are still the same. So with Dysport, this is about the conversion table, that for every 1 unit of Botox is going to be synonymous to 1 unit of Zeamin, and that's why I really like those two, because they're basically the same exact thing. And that's going to be to 2.5 units of Dysport. So as you can tell, you know, if I'm doing, you know, just 10 units, I'm doing 25 units of Dysport. And so you're obviously not going to charge the same amount per unit, and you'll get much higher numbers of units. So you'll talk to some people will say, well, my friend had to get 100 units or something. And it's like, well, typically it's not going to be of Zeamin or Botox. It'll be of Dysport. Now, some contraindications on these, and a lot of these are things that you would probably figure already. You know, neuromuscular disorders, reason is those people are typically taking them also relaxant already. This could potentially, this still has shown to have some spillage into the systemic body, but it's not something that we've seen yet that's provided anything that's, you know, been dangerous to anyone, that's hospitalized anyone. Of course, I'm, you know, speaking about normal situations here. I'm sure something exists where it doesn't. But the neuromuscular disorders potentiate some of those medications already taking. Clearly, if there's an infection in the area, you don't want to enter a needle in there and introduce that infection possibly in the bloodstream or anything like that. The severe facial asymmetry, and basically, you know, if they have severe facial asymmetry, and I do use the word severe, sometimes if people's eyebrows are a little higher on one side than another, then we can make Botox work and help relax that a bit. But something severe, yeah, let's be open-minded to the thing that you can't fix everything with Botox, and certainly it's not a bad idea to refer, you know, some of these people ahead of time to go seek someone like a dermatologist. You have aminoglycoside, antibiotics, like basically, again, it could just potentiate the effects of those, something like gentamicin. An anticoagulant, really all that's for in the alcohol within 24 hours. Although I can't say that at the Botox party, some of these people haven't quote unquote pre-gamed a little bit before they come in. But essentially all that really does is increase the opportunity for bruising. And really, it really has no other effect necessarily on anything with the Botox. I like to tell people to, you know, if you have an event coming up, try to do any kind of fillers or Botox. We do both in our office tonight. We'll concentrate just on Botox, but try to give it 2 weeks before you have that big event. So that's something I'll always talk about, and we'll talk about why in a second. Pregnancy and breastfeeding, look, there hasn't been any studies that conclusively show there's any issues. However, you know, it's a very hard thing to get people to be controls and variables that are with pregnancy and things like that, and to have somebody who's going to make a study like that. So we're still not going to find ourselves injecting for those individuals. And then there's people with body dysmorphic disorder. Certainly, this does exist, and it's very sad, and I have not run into it personally yet. But these are people that have an excessive preoccupation with some sort of imagined defect in their physical appearance, and these are just some of the, you know, unfortunately, I've seen men and women alike. nobody in my office particularly, but have heard stories, and certainly with them, you know, this is something that may be kind of a contraindication of using on those individuals. Now, side effects with this, there's really not many. Some pain at the injection site, very little, maybe, not much. From anecdotally, from speaking to patients about this, typically, if they do have any discomfort, it's mostly just a sort of touching the area, which I ask them not to do anyway. But they say about for the first day, maybe those specific injection sites are a little sore, but it's not common. The swelling, redness of the tissue, again, sometimes these are some of the ways that things could be injected. If it's injected maybe too shallow, you might get some wheeling of the skin, and that tend to see some of that stay around, swell, and become a little more red than some other ways to inject. Local bruising, again, some people, if they bump into a table, they bruise, and I'll ask them that, because I'll tell them, look, you know, don't be surprised if you get some bruising here. If you go fillers, especially, you'll probably get some bruising around those very vascular areas of the lips. So I'll tell them, you know, to try to mitigate those things. Ice is definitely helpful before and after with not only pain and the swelling, but also what we'll see is when you first give that Botox, it'll typically make almost like little red marks, almost looks like mosquito bites initially at every little injection site. However, a majority of the time, these are about down by the time they either leave my chair or about by the time they depart out of the parking lot. Very rare that it lasts much longer than that, but I do tell them ahead of time so that they don't get concerned about that. And a lethal dose here shows 5,000 units. And again, you're never going to go through that. I have also seen lethal doses lower in the 2,500 to 3,000 units range, but that's 25 to 30 vials of this stuff. Extremely challenging for that to occur. You're never going to go through even a vial on anybody. If you do, it's going to be because you're doing something such as underarms and things like this, but typically in our dental setting, we're not going to be doing much of that. And again, just to say this too, in contrast to how some people may joke about it, this is not an inherently addictive substance either. So now resistance, and you'll hear about some people talk about this, and I don't want to say it's a farce, but man, is it terribly uncommon. I've never seen it yet. I've done thousands and thousands of units of Botox by now. Nothing's impossible. If you look for it, you'll find it. There is something to that. That some antibodies could develop if you're administering too closely. We would rather them be, in some literature states, at least 2 months before you do another full dosage. Some say at least 3 months. But if this does occur, that it's not a forever thing typically, and then you can wait 2 to 3 years for that to recover, and then try again for them. But usually I try to wait at least the 3 months. I do have some eager people who try to come in sooner, and then I'll just I'm usually able to talk them into just waiting a few more weeks. Again, if this does occur and that Botox A and you're just convinced it's not working, then you may want to look into MyoBlock or the Botox B. But again, it's usually either underdosing, and you may just need to give a little bit more at what we're going to call our enhancement appointment. So again, another thing I hear about sometimes too is people say, well, you know, you're using the Botox for off-label use, and they make that sound like it's something very bad. And as we're aware, the FDA clearance is very arduous. And it's very challenging to get things through there. And so a lot of things we do in medicine and dentistry, some of these things are off-label use. Now, in order to get FDA approved, they only have to indicate one unique use for that. And after that, you can basically do whatever you feel is in your best, your best thoughts as a practitioner. Now, right now, Xeomin, Botox, Dysport, they are FDA cleared to treat. Initially, it was the moderate to severe glabellar lines, which we know was the 11s. The frontalis muscles of the forehead is something that's come on later, and then the lateral canthal lines in the U.S. And these are things we'll talk about in more in detail in a little bit. And so basically, again, off-label use is nothing bad. It's just that they may have not had necessarily a study yet on that. And mostly what can happen is, and you'll notice on the bottles, is like an allergen, and they can't advertise on their bottles anything that's not an on-label or FDA-approved use. So the FDA is really kind of mostly limiting them from marketing things, even though if they were to talk to you over a cup of coffee, and even if you read literature and textbooks, they'll show plenty of areas that you're using this that are off-label. So the FDA still, however, does not have any authority to limit the practice of medicine. Now, let's have this patient come in now. We have this inspection of the patient, and what am I looking for? Initially, like a lot of things, when we're actually even evaluating cosmetic dentistry, we're looking at these individuals and we're watching them talk and speak and laugh and smile big and some of these things. And we kind of like to do some of that during our interview process or while we're sitting there and speaking with them to see kind of their normal actions. Because when you ask them to exaggerate all these actions, it's a little bit different feel. So you'll look at them, you'll talk to them, you'll get them laughing a little bit, and usually you can make some fun jokes about Botox. And I like to see what they look like at rest, I want to see that if there's certain wrinkles that I notice are very deep, that, when they move, certainly maybe it's contributing some, but it might not be necessarily what we call a dynamic wrinkle, which would be a wrinkle caused by motion, but a static wrinkle. Then Botox may be part of the process, but a filler may be something that we may want to introduce as a possible solution to their issue. And then, of course, some people may need to seek something a little bit more dramatic and go to something like something else like a dermatologist. Now, some of the main motions I'll have them do is a frown. I'll have them raise the eyebrows. You can tell I haven't had any Botox. Smiling. You want to see any kind of wrinkles that may form. And just any kind of wrinkling of the nose. I'll examine them from the front and side views when they do this, so I can see any kind of wrinkles along the side, anything along the whole forehead. And this is primarily where we're going to be living, is the side of the eyes and the forehead. Certainly there's some other areas, but you can do quite fine and do a large majority of your Botox in these forehead, glabellar areas and the sides of the eyes, and that's what we'll primarily talk about tonight. And then palpation. And this is a very important thing because I've seen many times before where people will just look at a textbook and just see what that the anatomy is and about where that dot is that was drawn on this sketch of a person. And sure, that's not a bad place to start from, but not everybody's the same and everybody's musculature is a little bit different. And a very important part of my inspection is feeling their muscles and having my hands on them and saying, move your forehead up and down, and I can feel my hands moving up and down with the muscle. And that way I can find exactly where everything is. Most Pankey people are quite good with palpations from what we've learned, but make sure to not just use a generic roadmap. Feel those muscles, and that's going to be your main thing that's going to help. Now, if there's anybody who's ever, had a really good eyebrow raise and somebody that you can see some Frontalis lines on here, it's a young Jack Nicholson and obviously the later Jack Nicholson. But I hope you can see my pointer here, but essentially you can see right across his forehead how we're getting these horizontal lines. The girls in my office like to refer to them as the train tracks. Obviously, I'll never say that to a patient. I think that's a little rude, but that's some of the ways they'll see this. And these are some of the things that we can treat very easily with Botox. And I thought about Jack Nicholson a little bit more and I thought how this is probably what Jack looks like right now, spending time at home, although his home's probably about 19 times larger than mine. And then we're talking about the lateral canthal lines here. And here we have, oh my God, I'm forgetting her name. Somebody type her name. Now, certainly, she's very beautiful, and I would never tell any of these people that they absolutely, Gwyneth Paltrow, thank you, Anna. Oh my God, I'm embarrassed. Don't tell Gwyneth. I might still have a chance. But anyway, with Gwyneth here, again, you'll hear this question a lot, and I'm always very careful with it. I have a lot of girls ask me, because I'll say, where do I need Botox? And I'm always careful to say, nobody needs Botox. You're plenty beautiful the way you are. You don't need Botox. However, if you want some, I can help you with it. Sure. But I never tell anybody they need Botox. And interestingly, that's a great sale point. If you're in there wheeling and dealing like a used car salesman and telling them, yeah, you need to get some Botox here and Botox there, man, I find that to be such a massive turnoff. So I would always intimate to them, hey, you don't need Botox. You can still eat, breathe, chew, swallow, do all the main functions of life. If your life partner doesn't want to be with you because you have a few wrinkles in your face, then he or she's probably not the right person for you. But anyway, I'll get off that soapbox. This lateral canthal lines here is basically what we're going to call the crow's feet. These are words and lingo that they know it as. If I talk to them lateral canthal lines, they're going to look at me like I'm insane. Barry, I see your question about the average number of units for frontal, and we're going to go into some detail very shortly. So I'm glad you asked that question. And then Mary, I see, what about Botox to lengthen the upper lip to hide a gummy smile? And we won't talk about it individually tonight. Oh no, Barry, that's great. It makes me happy because it means that I've put information and that's useful. So please ask in case there's something I didn't remember. And that's a great question too, Mary. With that, I'm not going to have it in here, but certainly Botox is great to talk about a gummy smile. The other option, obviously, you can do crown lengthening and some other things. But I like it to be as a good start, is to give a little Botox there and let that lip naturally go. A lot of times that's not where they want to stop. They want to do Botox in other areas too. So it's certainly very great for to treat a gummy smile. Very non-invasive. I know, again, we hear about the word Botox, and the general public always equates it with these women with these massive lips that look like big hot dogs. And of course we know that's not Botox. That's, I guess I'll say, poorly done filler. With those, you can do it there. You can do it in all kind of different places. So we'll move on to the next thing, the glabellar lines here. And again, this is another gentleman, that I would never say, this is Marky Mark. Okay, he's Mark Wahlberg, but I'm going to know him as Marky Mark. The glabellar lines there, what I'm referring to is these 11s, is what we'll call it, right? These two things here, and this horizontal line. And then there's a musculature, that glabellar complex, that causes those wrinkles. And it's really going to be in Botox, one of the first places we'll normally see people with wrinkles. And I would tell you that it's a great place to always kind of focus on as your starting point. You always want to kind of have this thing where you want to always kind of have things move upward. And what I mean by that is I'd always start at this glabellar point and then treat the forehead with it. I would never treat the forehead without treating the glabella. You'll get some very odd looking ways of doing things. Typically they'll get some strange eyebrow raises or some drooping, or it depends on how you give it, but I would always involve this glabella as an absolute requirement, basically, for your forehead injections. Now we have our Botox toolkit here, and we're going to go through some of the things on how to use this. I've been in some other courses just when I was first training, and I never really felt like they told me enough about what I needed to get and how do I do this. So I'm going to try to do this with you. If you need more information, definitely feel free to let me know. I've got no problem with that. And we can take those questions here, or I'll even put my email as well in the chat box. So the reconstitution. So first of all, this stuff's going to come. We're going to look at it in a second. It's almost like a little powder. So these are some of the things I would first go and get. And so there's some people will say you'll get a 3 cc syringe. Luralox, one of the most popular brands of that. And some people will get this without the needle and then get a 22 gauge, like 1-inch needle or something like that along with it. And what this is going to do is insert into this bottle here of what we're going to reconstitute this material with. I personally get a 3 milliliter syringe that comes with a needle. BD sells it, very inexpensive, all there in one thing. Open it, boom, it's, everything's sterile and it goes right in. So what you'll do in here is you'll draw up, for our circumstances, 2.5 milliliters. Let's see, what training class you recommend? Yeah, so very great question. And I would always recommend at least taking one class. Now, will you learn everything there is to know about Botox? Well, like every other class, probably not. but you definitely want to take some classes, because a lot of times they will not cover you without some, as far as your malpractice insurance, without showing some proof of participation. There's many good ones. I do think that Maltzmacher's course is pretty good with the AAFE, American Academy of Facial Aesthetics. It's actually where I probably took my first course about 9 years ago. And that kind of started me down the rabbit hole, but I found that that was quite good. I thought they did a good job. The teachers were quite good. And then also the Dental Spa Seminars is a nice one. There's all kinds of good ones. Gigi Meineke does them a lot with AGD. I thought she did a nice job. So all those courses are really good. If you could take one that's live, and of course, a lot of times it only can be within your state if you're licensed, or and Dag put there, which I thought was good. I hope I'm saying that correctly. That you'll want to make sure, obviously, with your individual states, what your usage is. In Louisiana, I don't want to say we're lax. Yeah, definitely a hands-on course though, Barry. They'll have ones that are live patient, which there's so one interesting thing about dental spa seminars that you can do a live patient actually out in the Dominican Republic. I've done some implant placements with them, but you can also go out there and do Botox and fillers. And also there's hands-on courses that you can do if it's in your state, especially where you can bring individuals with you. I think it's actually called dental spa seminars, Barry. I'm not positive. I'd have to look and make sure I'm saying it right. I believe it's dental spa seminars, yes, sir. And then also there's hands-on courses that have just not mannequins, but we'll have the dead bodies. I'm sorry, my brain's a little fried like a lot of you guys after a 10-hour work day. But also with cadaver, man, thank you for saving me there. I promise I'm a dentist. And then the professor, Carmi, with the AAFE. I didn't have Maltzmacher proper. I had Tony Feck, who was kind of the guy who taught me initially. There were some other individuals there that had just taken several courses. They had a dermatologist there that I thought was good, that did a good job. But I haven't interacted with anybody from an AAFE course. I've been to a couple, in addition to several other kinds, but that I thought they were all very good, and they were all the same mindset. So I really think that if you get something from AAFE, that in general you're going to get the same education across the board. So, and then also at the bottom here, we're going to see that preservative-free is what you'll see a lot of times, especially on the bottles for Allergan and these things. And really the reason for that is that that's just what they did all the trials on. There's a lot of individuals who are doing, and dermatologists, I mean, these aren't just, people on Reddit just posting whatever they think comes to their head. Dermatologists, a lot of them are using sterile saline with preservatives, and that's what I was taught to use. The preservative is benzyl alcohol. Basically, the only contraindication is not using on neonates. We do get pretty young on the Botox. The youngest I've had, it was a 17-year-old. Was not my idea. It was the parents' permission. She had her breasts done and augmented at the age of 16. I thought that was a little aggressive, but she was okay to do that. But typically 25 years old would be about the youngest I would typically do that on. And again, you won't find me telling 25-year-old young lady, hey, you have to get Botox. Again, that's not what I do. So I would still recommend, I would still recommend the saline with preservatives. It just lasts longer. Typically without the preservatives, you can, after you constitute these things, you can refrigerate it for about 24 hours. They really want you to use it in. With the sterile saline, you can get up to 4 weeks. So how to reconstitute? Again, this is what the bottle looks like. You get it, and when you first open it up, you look and you're like, man, I got cheated. This thing's empty. But basically, it looks like a smear of this Botox. And of course, you saw how strong this stuff can be. So what you're going to do is you're going to draw up out of that preservative-free bottle into your 3 cc, 3 milliliter syringe, 2.5 milliliters of this sterile saline solution. Some individuals will do a little bit less, make their dosages a little bit stronger per. I would just stick to this recipe for right now. I wouldn't try to play around too much, and all these numbers we're going to go over is based on the reconstitution of of this vial with 2.5 milliliters. So I like to clean the bottle. I'm very big on being antiseptic and cleaning all that on top of the bottle. Alcohol is just fine. You insert that needle and I'll draw it up, and typically you'll just draw it up little by little. You'll go into that 2.5 milliliters. And then what you'll do is when you go to the Botox bottle, you'll insert that bottle. But once you do it, I would hold on to that tip, because it has this tendency to, once you insert, it's gonna almost like want to fly out of that syringe into there. And this Botox is pretty gentle stuff you got to deal with. It's got disulfide bonds in there, and it's very gentle, that disulfide bond. You don't want to break those down. They're very fragile. You want to preserve those until they get into the body. So you're going to want to hold on to that and just slowly let that stuff trickle down in there. And then after it's all in the bottle, you'll just want to just slowly rotate, and it'll mix that material. You really rather try to not make it bubble up if it does that, but you're just going to gently stir it, and there's no time necessarily to do it for, but you just want to be gentle with this material. Also, as an aside, when you do go after you reconstitute it, because initially what you'll do is you'll have this stuff in the freezer. The bottle is a little box of the stuff here. You'll put this box when you first get in the freezer. So when it's not constituted, just that smear, put in the freezer. That's going to be your longest way to preserve it. You never know when something like COVID will happen, and you're going to want to hold on to these things for as long as you can possibly use them for. After you constitute it, do not put it in the freezer. It's now liquid. It's going to freeze. Ask me how I threw away over $600 by doing that. I was a little upset with myself that day when it happened, but just part of the learning process. So this is the Botox syringes. There's a couple of different kinds. That the ones I see used mostly is they got the Botox syringe here. It's a 0.5 cc. And I'm going to show you in a second as to how this is equivalent to the units. BD, again, it kind of leads the charge there. They're very inexpensive. Comfortox is another kind I've used before. Malzmacher pushes it. I have some. I got some sent to me as like a sample. To be honest, people feel more comfortable with the regular 0.5 cc. They're going to have these ultra fine syringes. People just have felt more comfortable with those. I've asked them. Comfortox is definitely not bad, but you're going to probably end up a little bit less expensive and probably more comfortable with the BT syringes. In addition to comfort, interesting, when we're talking about the preservative and the preservative-free, studies show that the sterile saline that's preserved has actually been found to be more comfortable with injections. And there's several studies that say that that's the case. Now with Botox, and again, this is something that was confusing to me at first. And if it's confusing to you as well, no problem. You know, I get it. Let me know. It's not an issue. But this is going to be very just kind of cookbook style here. You can obviously take some pictures. I'll share the slides if you want them. I'm not, I don't have any, any interest in selling anything or anything like that. But I want to describe to you where the unit dosage and stuff come from. So we have 100 units of Botox that's going to normally be in your vial. That's going to be a pretty standard size for Xeomin and Botox from Allergan. We're going to now put 2.5 milliliters of that saline in there and reconstitute it. When you do that math there, that comes out to be 40 units per 1 milliliter of solution. Now you're using a 0.5 milliliter syringe. So in each one of these syringes, you're going to have 20 units. So when you hit up all the way up to the 50 here, you'll have 20 units in that syringe. So sometimes this gets where it's a little bit confusing, but again, do the math. Every 10 units, or I'm sorry, let me go back. Every 10 on here, Jordan, what I'll do is maybe Dylan, maybe there's a way, or whatever you suggest that's done in the past, Dylan, that I can just dispense all the slides to everyone. Or I'll go ahead and put my email right now in the chat box and just email me and I will go ahead and send you the slides. Absolutely, Jordan, thank you. So every 10 is going to be 4 units. There's 50 units. There's 5 things of 10. 5 times 4 is 20. So every 10 on this is 4. That means when you go to the 20, you're going to have 8 units. And then the 30 is going to be 12, and 40 is going to be 16, and so forth on the 20. Now, every 5 on there is going to be 2 units. The reason I even bring this up is because there's going to be areas where you're only going to administer 2 units per injection site. And then again, fill in the blanks with there. Every 5 that you go, you go 2, it's going to just keep jumping, you go 2, and then the 4, then the 15 is going to be another 2, and you just keep doing the math like that. This is probably where it gets the most confusing, but it's very easy once you've done it a few times. Now, one thing I'm very big on is being clean. I used to just use an isopropyl alcohol on a gauze. Now I've moved to this Prevantix. It just has the chlorhexidine gluconate in there. It's been described to me by some dermatologists, and I'm sure you talk to one, they're going to say maybe something a little different. But they've said this is kind of the quote unquote gold standard for making sure that you've got an antiseptic area. I think you can never be too careful. Again, Botox is not something I see as dangerous or invasive, but you always just want to, you want to do everything you can to make sure you're practicing everything as safely as possible. So I'm wiping their face before I inject. I am injecting. I am wiping again as soon as I inject. I'll wipe the next site. I am almost a manic about it, but people really appreciate how clean you're being with it. And a lot of times if they've been injected by someone else, they're not doing the same thing. And so being completely clean with them and keep telling them, look, I'm sorry, I'm just a clean freak. They really appreciate it. And it's one of the things I've heard from patients as to why they also like to continue to come back to me as opposed to someone else. There's some other extra materials you can use. You can use Emla cream. Typically, if you're going to put that stuff on there, it's got, again, Prolicaine and lidocaine are in there. It'll tingle on that area for about 15 minutes, but usually you want it to sit there for about an hour, and you'll cover it up and bandage it. Again, I'm sure people have gotten shorter durations and stuff, but typically it's about what's recommended, and it'll last about 2 to 3 hours. I can't even say the name of this thing, but it's a good stuff in the fact that you don't need to cover it with anything like you would with Emla cream. This is a higher amount of lidocaine at 7%. It's got a 7% tetracaine in it as well. Typically, it takes about 30 minutes to get pain relief with this. Again, I would leave it on for probably an hour if you really want to feel quite solid with that. This will actually form its own membrane, which is nice. So you don't have to cover with anything, and you can just peel that off and then start injecting. On the lower left, this is just an example of any kind of ice pack is fine. Before and after is great. It mitigates really the chances of bruising. Certainly, it can also make it for more comfort. And the other thing that I would suggest on here is the makeup pencil. It's something that's very good to go ahead, and you'll see in the next slide where there's some little marks of where somebody used a makeup pencil. I think what you do is you palpate your muscles. You put your makeup pencil spots here. Sorry, I was checking my time here, making sure we're doing okay. And that'll give you some comfort when you go back to the face. I think as time wears on, you'll probably put the makeup pencil aside, but you'll use that to mark where you want to be. I wouldn't put the injection into the makeup pencil spot. I would put it maybe just right adjacent to it. To me, Botox, I've had many needle-phobic people that have no issue with Botox. They have no discomfort, especially with the way we're going to talk about in a second with injection technique. I don't think I would really spend any money on Emla cream or this other stuff. If you want to use it because maybe you're going to use that as something for to put on the area before you numb them up for fillers, or if people want to do fillers, then maybe use it for that. But I don't want to say waste your money. Anything you use for patient comfort's never a waste, but I don't think I would go out of my way to go spend a lot of money on this. So what we're going to do is talk about now the injection techniques. Now, there's 2 different ways I would do this. And interestingly, this is probably the #1 thing of what patients who come to me that have been to their dermatologist before say is different. And they usually say, wow, that didn't hurt like my last injection appointment. And I hear it all the time. And it feels weird to me because this is how I learned it. But you'll notice you'll get a good pinch of the skin here, a good grab of that skin. That musculature is going to come up with the skin. Remember, it's pretty shallow right up underneath that skin. And you're going to inject just about halfway in. there's different, and I say halfway in, there's different places to inject. If you're in the masseter muscle, for instance, you're going to sink it to the hub on these diabetic needles, in some other areas. But in this area right there, that's a pretty good looking of what you should be looking like when you do it. You're going to want to really get a good grab of skin. That's the thing that doesn't hurt people. That's the thing that's going to have them continuing to keep coming back to your office, is doing that. Another thing, another strategy is sometimes it's hard to pinch their skin. Well, that's because you've been doing Botox for them and their skin and their collagen is pretty tight on there. And I'll even kind of joke with them. So but if I can pinch it, I will. And so the second thing I'll do is I'll do a stretch and kind of angle it in. You can notice how both of these injection sites is a bit angled. I'll stretch and again, angle it in, not just go down straight towards something. But this is another way that makes it more comfortable. I see this on the internet and I'm looking at, this is how some people say they've been injected. And I'm thinking, man, no wonder people don't want to go back to that person. And I'm thinking almost, man, thankfully they are doing it that way, because that's terrible for them. And that's going to get them to keep coming back and seeing me. So again, I can't harp anymore about how much, please, please, please go ahead and get a good pinch of that skin and you're going to do great. Oh, thanks, Dylan. I promise for everybody's time, though, I'm not going to try to go too much farther past the hour. I am respectful of y'all's time, but thank you very much for that, Dylan. So we're going to talk about some very common areas here, okay? So you have the glabellar muscle complex. Again, I start here because that's the place I usually start for somebody. The glabella is going to basically be in this complex. You're going to have the corrugator supercilii, and you're going to have the depressor supercilii and the procerus muscles here. So it's going to basically be all in these three guys right here. Now, what they're going to do is they're going to be able to elevate the eyebrows and the skin of the forehead. You're going to want to stay about 2 millimeters superior to the orbital rim. Very important if you don't want to cause ptosis of the eye, where it's just sagging down, which some people have had. Hey, will it ever happen? If you do enough of anything, it'll happen. Will you break a file if you do enough endo? Will you perforate a bony wall with an implant? I mean, these things are going to happen if you do them enough, but certainly you want to try to avoid them. And what you're going to do is just kind of measure it out. Typically, I will feel for that orbital rim, and I'll give myself about a finger, and I'll go up above that finger to make sure I'm over that and not injecting straight over that area. And then these are the ones that are going to produce these horizontal wrinkles here. So we have the procerus muscle in the middle. That's going to be kind of the first place you're going to inject, and we're going to talk about how many units there in a second. This is going to basically pull the medial side of the eyebrows down toward the nose. So, and then you're going to have your corrugator, supercilii, and the depressors, and what they're going to do is pull medial and downwards. Those are going to be the ones that are going to cause those kind of vertical ones out of the 11s. That procerus is going to be the one that's going to cause that horizontal line that we'll see more illustrated in a second here with Marky Mark. So you can see here, these two here, the corrugators and the supercilii and the depressor is going to be the one that's going to make those 11s. And that procerus muscle pulling down is what's going to make that horizontal wrinkle line. And again, that's just to illustrate what's going on there. So what I think about this, I look at these muscles and I look at these wrinkles, and I think about this area as a triangle. And what I'm going to get them to do is I'm going to say, and I use a lot of really technical jargon when I deal with my patients. I say, make a scrunchy face for me. And they'll go, make these weird faces if you can see my face. And when they do that, just like I'm probably doing, I'll notice these two 11s, and I'll notice this horizontal line. And in my mind, I trace out a triangle, and I'm going to go dead center in that triangle with my injection site. Boom, right in there. That's going to be my injection site, and right in the middle of that triangle. And then I also want to get those other muscles here. So I'm going to get the corrugators and supercilii, and the depressors are going to get basically with the same injection in that area. It's going to diffuse in both of those. And that's going to prevent these from pulling inward. And this is how many units I'm going to give in that area based on what we have. Now, everybody's a little different, right? If they're extremely expressive, I'm going to still start with 4 units. But no, in the future, don't tell them not to be shocked if they're going to maybe need a little bit more at our enhancement appointment. So we're going to do 4 units there in this area. This tends to be a much stronger muscle than versus the frontalis muscle, which is a little bit of a thinner, kind of more sheet-like muscle up there. And speaking of the frontalis muscle, we're going to go to that now. And basically that's this big area up here. And what this does is going to elevate the eyebrows and also the skin of the forehead. Again, we want to stay 2 centimeters superior to that orbital rim. And this thing is going to produce those horizontal train track like wrinkles there. So we go back to Mark here, and we're looking at him, and what I'm looking at here is these frontalis injections. And if you think back to this, we want to give some here, because the scalp is going to be about this area right here. It originates about right underneath that scalp, and it's going to insert right into the eyebrow area there, underneath this orbicularis oris. And so, oculus, sorry. And so we're going to give I'm going to show you the units in a second, but I'm going to have them give me the surprise look now. So I'm going to say, give me a surprise look. And a lot of times they'll make the surprise face. They'll do that with it. You know, for some reason that's almost obligatory. And they'll go up and down and up and down. And we're going to feel where those muscles are lifting, and we're going to palpate all of that. And what we're going to do is we're going to give some in these areas here, in that upper portion of where you see it move. It's going to be a little bit weaker of a movement higher up in that area. So we're going to give a little bit less in that frontalis muscle that's up here. You're going to give a larger amount of dosage here and here, because that's where that orbicularis oculus is. And those are going to lift a bit stronger in those areas. And if we don't do those, that's when you're going to get those crazy Jack Nicholson eyebrows that can continue to raise. So you're going to give those on those areas there. He did give the end code, so we don't have a lot left, but I understand if you need to go. It may hurt my feelings, but that's okay. So this is where we're going to go with this. We're going to go ahead and give 2 units in those upper ones, and also in this middle. Some people will have this middle band of the frontalis muscle here. So I would also always incorporate this. I usually look for this wrinkle, and I'll give it right in the middle of that. In the upper, if you're starting to see some, I like to kind of follow those wrinkles. Typically those wrinkles are there for a reason, and that's because those muscles are contracting and forming those little wrinkles. Okay, we're going to keep speeding along here. Almost done. Orbicularis oculi muscle. These are going to close the eyelids. You're going to locate that bony orbital margin, because we're going to give that right along the side of where that is. That's going to be our area to palpate here and feel for. And this is what produces those crow's feet. So again, in Gwyneth here, we're going to look a little bit more closely, but we've got her little crow's feet here, and we're going to tell them to squint a little bit. And that's what she's doing here. Maybe the sun's bright. One of the big reasons that we'll recommend to people to use sunglasses is so that they can lessen how much they need to do that. Again, I would harp on people with this. You don't necessarily want to take away all ability to squint a little bit. When people smile, part of what makes that smile engaging, especially in a COVID era where we can't see our face actually smiling, or our mouth smiling, is that this still gives that appearance of a smile. So you're going to tell them, hey, we're going to just basically diminish the activity a little bit of this to smooth that out, but we're not necessarily looking to completely take away the full-on ability of that to happen. So what I look for here, and we're going to give it in 3 different areas, about 1 centimeter apart from each other. And what we're going to do is a lot of times I'll look for each one of those little feet, and I'll give some here, and I'll give some here, and I'll give some toward the base right here. And I'll go 4 units each on each of those. And so, you know, this will be 4, 4, 4, and 4, and 4, 4, and 4. And you're going to want to, the way you're going to want to be to avoid any kind of itosis or any kind of double vision or anything like that from a diffusing tube is find that bony orbit and stay a little bit lateral to that. And this area here, I can tell you of all the injection points, this is the area that's going to be the most sensitive. So I would tell them when you give it in that area, say, hey, you know what, this area right here, a little sensitive on that more lower portion of that lateral canthus line area. But so anyway, that concludes as far as that portion. Just some little parting thoughts here again, and sorry, moving a little bit more quickly, but I want to try to get close to the time. I'd ask patients, please don't touch the area for at least 1 to 2 hours. Why is that the case? we really don't want to disrupt the Botox. We don't want to help move the Botox too much out of that area. We want to allow it time to deactivate that snare complex and to allow that area to work and not allow those things to bind and conduct those pulses. Please don't love it or hate it for 2 weeks is what I tell the patients. Again, it takes about 2 weeks to hit its maximum effect. So this is why I tell them, you know, give it its time to do that. At that point, I don't say that it's a touch-up appointment or anything. I call it an enhancement appointment. This is something I got from Maltzmacher. I thought was a great way to phrase it. And tell them that's expected. Hey, you might need a little bit more. Yes, it's your first time with me. Let's start at this dosage. And yeah, you've had that in the past, but let's make sure, let's err on the safe side. We can always add a little bit more in a couple of weeks. And so you get them back. Do I charge them for this? I do. And I'll try to tell them up front, hey, I'm going to do a lower dosage because that may be all you need. I'm trying to save you a little bit of money here. Hey, maybe you need a few more units, but typically it's not nothing that's going to break the bank for them. I tell them not to do any vigorous activity for 3 to 4 hours. And again, that's just so that we're not increasing that blood circulation, which could wash away some of that Botox from the injection site area. I'd rather them not manipulate that area. Don't go get a facial, chemical peel, microdermabrasion, any of these things for about 3 to 4 hours after your treatment. So typically you're going to do all, but you can do those things prior to the Botox. So I just don't want you to do those things 3 to 4 hours after. You can go ahead and move your facial muscles around if you want to. Tell them exercise a little bit with the face, move it up and down, squint a little bit. Some people I've seen some things that say that they feel that this stimulates a little bit of the toxin binding, but that's on their own accord with the muscles, just moving that stuff around in that area, not them physically taking and massaging it around. And of course, which is an important thing, yes, you may reapply your makeup afterwards. The summary with this is a lot of people think Botox is a little scary, and it's crazy because some of these people that tell me this are people putting in multiple implants and doing full bony impacted extractions and many other things. This is a very easy thing to do. If you need somebody just to kind of like be with you once or twice to show you, you get the hang of it quite quickly. And the only way to get better is to keep doing it. People at your office and your family, it's funny, they don't really want to volunteer, right, for that first root canal, but they like hell will definitely be there for Botox. It's not a hard sell. The average price per unit, again, as we kind of talked about before, was about $10 to $15 a unit. I like to dictate how many units are needed so that they're not saying, I just want 4 units and you kind of got your hands tied as to what you're going to do. That 2 weeks enhancement appointment. And again, you just keep doing this like everything else, you'll get better at it. So that concludes everything. I know that Dylan already gave the end code. I'm sure that he'll repost it again if anybody's just finishing now and didn't happen to write it. And I really appreciate everyone's time. Absolute honor to speak to great clinicians such as yourselves. And thank you for your participation in Pankey. And I hope to see you guys at more of these meetings and at our virtual annual meeting that is sure to come soon. And thank you very much for your time. If you have any questions, I'll be here answering some chat. So Hillary asked about how many, what percentage of my practice is this? And I'm telling you now that I've got more associates at my office, this is increasing. And it's really a word of mouth thing. Thank you very much for the people that tell me thank you and great presentation. I really appreciate that. That really, I was a little nervous about it. I wanted to make sure I didn't bore you guys. So hopefully it was fun. And then, but it's becoming about, for me at the moment, because I still practice rote dentistry all the time, but I'd say it's starting to creep into the 10%, which is quite high. I do plan on giving more and more of my other activities to the other associates, which would increase my time and my concentration and probably my marketing on this as well. And that's just Botox. I do fillers as well. And mostly for that, it's lip augmentation and filling in the nasolabial folds on people. But my thought is to move more into this and treating my TMD patients. CE on filler, Miriam, great question. Again, those same companies will offer filler on CE. Filler I found to not be quite as awesome yet in courses. I actually learned a lot more about filler. Now, I did take the filler in courses because I have to get covered. Again, AAFE did it. A lot of times they know that if you're going to take the Botox course day one, that day two they'll have the dermal fillers because they know they're going to get a lot of repeat business of people staying and taking those classes. You can go do the live thing in the Dominican Republic where you can actually get your hands on patients to do it there. I found that I learned a lot about fillers from watching some videos on some people doing them. AAFE actually had some DVDs. I found those were helpful. And also reading some books. There's some great literature out there. I don't have the book with me. It's in the other room right now. But if you email me, I'll be happy to email you the title. I thought that was a very great book for me to sit there and really study it. And then when I went to, and then just doing it gets you quite comfortable. Do I use it for migraines or TMJ pain, Gary? You know, I don't promise them that it's going to take away their migraines, but as we're aware, if somebody comes in and says, oh man, my masseter muscles, you know, I'm having some issues there, and they're not going to say masseter muscles, right? Oh, the sides of my face have been hurting, and I've noticed I've been clenching more, and I'm having some temporal headaches. Oh, I just start licking my chops, right? Because I look at that, and first my thought is, all right, I'm going to put you in some sort of, you know, a splint or some sort of deprogramming where typically I'm going to try to lessen the activity on their back teeth initially. So that I can start deprogramming and shutting off those masseter muscles, and then maybe over time start to walk them back. But for some people, I'll do the Botox in those areas because they don't want to wear a splint. But I never say, and really this was because of my conversation with, unfortunately, he's recently passed, Henry Grimion, and he told me, Chris, we really don't know what the long-term effects are going to be down the road in 50 years with constant use of Botox in the masseter muscles. And so he's like, so therefore I'm not keen on doing it all the time, but I do it for some people if they don't wear a splint because they just refuse to, then I want to help them still. So I give them that, but I always tell them that, hey, this is sort of a Band-Aid. You know, let's go ahead and try to think about a splint at some point. So I wouldn't say that it's my substitute for it, but I do use it for them, and I do get great effects with it, especially if I know they're clenching. And some people I use in conjunction with a splint. They need both. But yes, I do use it for that. Yeah, the presentation, Peter, will be available later. I believe that Dylan's going to post it, or they're going to have it posted online in perpetuity. My email address, I'll go ahead and type it again. And then let's see what else we got. Thank you guys for everybody saying such nice things. What's my opening line? Yeah, very important, Joy Marie. That's a great question, man. I tell you, a lot of times just mentioning that you do it or being in the room, they usually bring it up on their own. It's a very uncomfortable thing to say, hey, ever thought about Botox before? Maybe with the muscles, right? Because that's a little bit of an easier sell because I'm addressing as a treatment. But if I ever say anything, it's about with some like talking about something else, and be like, and they might say, well, do you do this or that? Yeah, and man, I even do Botox and fillers and things like that. And they'll start asking questions. Oh, you do that? You know, because we're dentists, we get it. It's not common, but I do believe that as dentists, man, we know our facial muscles extremely well, and the technique is, I think we're more. I mean, who's better with needles than we are? I mean, my God, I think part of the reason that the injections they're saying is very comfortable as opposed to a lot of their dermatologists. And that's not tossing them under the bus. They're great. But I'm just saying what happens a lot as I get them to come in is I think that we pick up needles a lot more than they do. It's just what we do. So if anybody's good with a needle, we are. But the opening line is, you know, again, I sell it by not selling it. I say, man, you're beautiful. You don't need this. But hey, if you want something to help preserve it, and keep that around longer and not be subject to any wrinkles, you know, we can do that. But I tell you, the opening line really has just been making people aware of it, and they ask about it. But it's not an easy, comfortable thing to just say, hey man, I see some lines in your head, you know, you need Botox. So that's been mostly, it's just the awareness, and I usually couple it in with talking about something else. Let's see what else we got. Is it effective for bruxism? You know, Lynn, I think there's different schools of thought on it. I personally have found it effective for clinching for sure. And I tend to find that some of these people's habits get mitigated a little bit by the Botox. I know that people advertise as being that. I'm still not comfortable necessarily promising someone that they're going to stop bruxing because of it. I do think that with the clinching, I can get them to lessen that at least enough to where it's not going to be destroying anything or being destructive to the system. So with bruxism, I still don't say that, but it does help relax the area a bit, and I do find that it will lessen some of the bruxism. But I still don't promise it as something that I find is incredibly gonna turn it off like it would with a clinch. Yeah, Monica, thanks. Yeah, I figure I would go with the bread and butters on the upper portions with the Botox injections. Certainly on the lower portions, and I'd love to talk about the masseters and such. Masseter is a very that's a no-brainer one, and I'll give you a little quick demonstration what I do. But I typically will find their zygoma, the zygomatic bone, their cheekbone, right? And I'm going to put a finger there and feel it. Then I'm going to find the inferior border of their mandible, and I'm going to put my thumb right there. And I'm going to ask them to clench and clench and clench, and I'll move it till I start feeling the upper and the lower portions of that masseter muscle contracting. And then I will start to go on the other side, the horizontal portions of that masseter, clench, clench, and I'm going to feel all around that ribbon. And then I'm going to just basically aim right in the dead center of that ribbon, sink it. And for women, I will usually give about 12 units. I like to go lower. I've had one person when I gave them 15 that they had a hard time chewing. So it scared the hell out of me. So I've been staying at 12. And then for men, I'll go 12 to 15 on women generally. For men, 15 to 20, typically I'll sink it in on that. There's definitely great ways to do smokers lines, which is kind of almost synonymous with we were talking about before with helping with correcting the gummy smile and some other areas. How long does it last? Jenny, I'll tell people that in general, it lasts 3 months, but everybody's, physiologically a little different. And especially if their muscle's super strong and never had it before, don't be shocked if it's more in the shorter end of the spectrum, maybe the 2 to 3 month time. But I also tell them on the other end of that spectrum, as that muscle atrophies and weakens a bit, when I give you that same dosage, it'll potentiate a little those effects, and typically you'll get longer than 3 months with time. Thank you, Lexi Richmond, for being here. So Lexi and I work together. We're very proud of her. I hope that somebody recruits her out to Pankey. Lexi was an assistant with me, went to dental school, and is now practicing as a dentist with me. And I'm extremely lucky and fortunate to have her, and I would love to have her involved with Pankey. Do I use the arnica gel? You know, I don't I don't really use anything to numb for Botox. I really found that it got very little effect. People typically don't have a lot of discomfort with the injections. And especially when you use that either stretch technique, which I would kind of say is second to using that pinch. That good pinch technique is definitely the way to go. So I usually don't use that material. Even for the people who are very needle phobic, they do like the first one and they're fine. And so I don't use it personally, but would I tell people to avoid it? No. I mean, look, if it helps people feel comfortable and you've got the time and they're okay with applying some of that gel and sitting there for an hour or having it themselves and applying it before they come in, yay, go for it. I think that's fine. I think you'll get almost an easier effect by using ice. It's cheaper, it's easier to get. You don't have to worry about it going bad. And then you can put that on there, let them hold that for a bit. That also helps constrict some of the vessels, makes it a little bit, shrinks the vessels, makes it a little bit harder to hit a vessel by accident. And it also is good for controlling any bleeding as well. Great, yeah, another great question. When the patients are older, typically I'll use the same amount, but I also let them know that the deeper that fold is, the more that we're probably not going to take it away. You know, by now they've lost just some collagen, some elasticity of that area. It's going to be probably a combination of the two. I still want to mitigate that muscle movement, but I'm going to also couple in filler in some of those areas if they really want to start trying to really flatten out those wrinkles. I do tell them, hey, look, you want to look, I hate to say age appropriate, but you want to look a little age appropriate. You know, if you're 75, don't try to look 30 or 25. I mean, age gracefully. We can diminish those a little bit if you want to do a little filler to kind of flatten some things out. But I still think it's beautiful to have some lines here and there. And when you smile, to still have some dimples and not flatten them all out with filler. And when people smile, you know, to still have a little bit of squint, you know, went to their eye and not completely be gone. So, but I don't use any less necessarily. I would still use the same amount as normal unless their muscles dictated one or the other. If their muscles barely moving, then maybe I'll give a little bit less. If their muscles moving like normal, and that's just from watching them do the motions and palpating that. How many enhancements points do you tell folks? I just tell them we're going to do one. After that, you know, I tend to just tell them after those 2 weeks, it'd be better off if we really just decided to wait. Now, there are some people that are okay with saying that, and there's some, when I say people, I'm saying like literature. It says, yeah, you can keep coming back 2 weeks, 2 weeks, 2 weeks. But I haven't had anybody yet come back for a second enhancement appointment. I tend to try to talk them out of it and say, look, you know, let's give you some more here and just see how this does. And then in a few months, it would be better if we revisit. And then we'll know, okay, we're going to move up in dosage and go from there. And I haven't had anybody yet that's needed to come back for a second enhancement appointment. How do you treat the horizontal lines near the upper lip? So I guess you're talking about like, maybe, are you talking about those little, if you're talking about those little vertical lines, we call those the smoker's lines like that. And what those will be is we're going to give, we basically give about 1 or 2 units in that area, just like a little, like, I'm trying to think of how to show it to you, but on my lip, if I just took about 4 dots and just did a little bit here, a little bit here toward the philtrum, a little bit here on the other side of the philtrum, and a little bit on the other side, kind of between the philtrum and the angle of the lip, that's where you would give that. People also are familiar with what they call a lip flip, getting very popular now. It does work a little bit. I wouldn't say it's synonymous with a filler, but I think it's a great introductory thing. And and it's, a lot of girls don't necessarily need a bunch of filler in their lip. And what that is you just go, again, it's hard to show on here, but you're going to give just like one little bitty 1 unit and 1 unit, 1 unit and 1 unit, right where that vermilion border is on the upper, where it joins the skin. And that's enough just to weaken it a little bit, because over time, our lips have this tendency to want to kind of come in. And what that does is it relaxes it and the lip flips just a tad, a little bit. And I just started doing that recently because I've been asked about it. And yeah, it works. It's pretty good stuff. Thank you, Nora. I appreciate your time for coming to see me. So, all right. Well, again, guys, thank you very much for your time. You can email me at any time. Be happy to share. If I don't know the answer, I'll look it up and try to get it for you. And thank you again for logging in, and continue to keep coming in and watching, everybody. And thank you again for your time. Y'all have a wonderful night and good luck and stay well.